now. And we will go ahead and get started. Let me pull up my materials here. Okay. So thanks to everyone for bearing with us. And it feels like just yesterday that we were all together, since it was just a few short hours ago. I know there were some comments yesterday on everybody feeling a little bit like they're drinking from the fire hose, and I just want to acknowledge that that is a reality of this project. So yeah, thanks to everybody for putting in the time. I am going to just talk about our agenda really quickly. Glendora, then if you want to kind of welcome and introduce us, and then we'll kind of get into it. I think most of today is set aside for us to have some discussion, but I did want to just remind us all of what the requirements are of the legislation and the task force for this this tag, and also share some information on what our current status is with regards to eligibility and enrollment, knowing that we are trying to get away from our current status, but I do think that it's important for folks to just have a common understanding of where we're at, hopefully illuminate some of the barriers, and I know that you all have a lot to share in that regard as well. We have some discussion questions to get us going on eligibility and enrollment issues, and Glendora and I are still working out our best approach to coming up with discussion questions that really get folks to sort of to illuminate some of the issues that we need to bring forward. But hopefully this is a start, and we can get some good questions and content and discussion. We're going to end with talking about what we want to put in front of the CAC. You know, what are the consumer issues that we really feel like out of this discussion need to be highlighted, as well as for the task force, what we want to put forward to the task force. As we saw yesterday, you know, I think we're still getting our groove here, but we do want to have some sort of way of reflecting back to the task force so everybody on the task force knows what's happening in the tags. We are supposed to have 10 minutes of public testimony, where we have 10 minutes set aside for public testimony, and we'll see if we have folks who are interested in that. And given our technology glitch here, I'm not sure if that's going to be the case or not. Let's see, Glendora, is there anything you want to say as we get ourselves started here as our lead?
No, I think the only part I was going to play was to reiterate what you've said about the agenda for today. So you've done that, and so I would just like to say that hello everyone, welcome to our second Eligibility, Benefits, and Affordability Technical Advisory Group meeting. Did I say this was our second meeting? If not, this is our second meeting, and we have 4 members. So my name is Glendora Claybrooks. I don't know if I said that. Bear with us. We are working through the technicalities here. So I am going to have each member of our tag group introduce themselves and share a bit about their expertise and why they are chose this tag to be a member. So I'll start with our co-chair of the task force on universal health care, and that is Vice Chair Ed Junkins. Take it away, Ed.
Hi, Glendora. Thank you very much. Can you guys hear me okay?
Yes.
First of all, I'm honored to serve as the vice chair of the Joint Task Force on Universal Health. Really, this is a joint effort, as is in the title, between community members, volunteers, the legislative team, legislators, and really the concerned people who come and offer public testimony. We have had really terrific stories and ideas that have come out of the public that is reassuring us as a group. Technological glitches happen, and they usually can't be avoided, as is presently. And I'm apologetic that it's happened for this meeting. And I value, and I think I speak for really the team, we value public input in whatever way we can get it. And if the only way to participate in this case is to view this recording and then to reach out, please do so, because the testimony is super important. I am from the Western University of Health Sciences in Lebanon, Oregon, the Osteopathic Medical School, and it's a pleasure for me to be here today. Glendora, thank you.
Thank you. Dr. Zinnia Junkier. Sorry if I botched your name again.
No problem. Yeah, hi everyone. Zinnia Junkier, she and her pronouns. I'm really happy to be here today. The experience that I think that I'm trying to leverage in this space is doing a lot of community-based work with organizations and individuals, working with populations who have OHP as a naturopathic provider myself, recognizing the limitations to community members being able to get access to the kinds of care that they want to get access to. And so I really bring a perspective of wanting to ensure that people in our communities most impacted by health inequities and disparities are able to receive the coverage that they deserve. So that's kind of the background on why I'm here today. Thank you.
Thank you, Zinnia. And that's it, except for I didn't describe who I am. I am also a member of the Joint Task Force on Universal Health Care, as well as the chair of the Consumer Advisory Committee and the lead of our eligibility benefit affordability tag team. So that's who I am. And at this time, I'm going to turn it over to Sarah.
Thank you, Glendora. And yeah, I'm Sarah Nipper. I am the OHA staff person who's part of the team that's working on this task force, and I am helping coordinate this particular tag. I just want to reiterate what Dr. Junkins said about the importance of public testimony. There is a link on the website where folks can email in their written testimony. It does look like we may have had a few folks join us here this morning, and so that's great. But yes, if you are listening to this recording, we will definitely take your testimony, of course, over email. And we will be presenting that at each of our successive meetings, so folks have an idea of input from the public, because that is really crucial to the work that we're doing. So thanks for emphasizing that. Okay, there we go. So I'm gonna just quickly go over a few slides that should look familiar, because I presented them at our first tag meeting, but as a way of grounding us in the work that we're doing, I think there's a lot to be done, and this is a way of helping us kind of focus. And so at the task force meeting last night, the larger task force affirmed, I think largely affirmed, the charter and scope of the tags. And so this was what we had laid out as the 5 big buckets of work for this particular tag. And so for today's meeting, we're really, from a content perspective, I think we're focusing on this first piece around eligibility criteria, which also gets at enrollment. And then the 4th and 5th pieces are really infused throughout all of our tag meetings. And so they will be front and center at each of these meetings. And so the 4th one is around health equity, talking about, you know, disparities, and not just disparities, but how are we, the recommendations that are coming out of this tag, how are they really geared at closing those gaps and achieving health equity. And then the last piece being, as I mentioned earlier, flagging what things we want to make sure go to the CAC. And I think for this particular tag, we are blessed having Glendora being the chair of the CAC, as well as the lead of this tag, and really helping us make sure that we are keeping those consumer issues front and center. Again, just as a reminder from the legislation, and this language comes from a summary that Oliver had put together, but this directly speaks to the charge of this tag. So the requirements of the plan that are outlined in the legislation, when it comes to eligibility, the plan shall allow participation by any individual who resides in Oregon, is a non-resident who works full-time in Oregon and contributes to the plan, or is a dependent of either of the first 2 categories. The other pieces that are, I think, particularly relevant to our discussion today, in the design of the plan, it must ensure that individuals who receive services from the VA or IHS may be enrolled while continuing to receive those services. Allows people to be included in the plan without decreasing the ability of anybody to get health coverage if they move out of state. And then, of course, preserving the coverage of services under Medicare, Medicaid, CHIP, and the ACA. That gets a little bit more into benefits, but I wanted to make sure that we just sort of had these as our grounding. We're going to talk about this, so I'm just going to skip right over this slide. I'm going to spend a little bit of time talking about just providing some data and information about what is currently happening in Oregon. I know not everybody gets as excited about data and graphs as I do, and so I'm trying to temper my that tendency in myself, but I do think that if we want to think about where we're going, it's important to know where we've been and where we are. And so I'm sure this isn't new information to a lot of folks, but I just did want to spend a few minutes looking at what our insurance landscape looks like, who has coverage, who has access, and then why they may not have coverage or access at the moment. And so I'm going to go through some slides on this, and then you know, if there's questions about that, you know, or discussion about those items before we move into the larger discussion. Some of these slides you have seen before. Jeremy Van de Hey presented them at one of the very early task force meetings. But a lot of this information comes from our 2019 Oregon Health Insurance Survey, which is showing that most Oregonians do have some form of health insurance. It doesn't mean that it's necessarily comprehensive, but 6% of our population in Oregon is uninsured. That 6% represents almost 250,000 folks. So that's a significant chunk of people. We have made a lot of gains in expanding coverage in the state. Back in 2011, 15% of our population was not insured, and that is down to 6%. But our gains have really stalled since the Affordable Care Act was implemented in around 2014, 2015. And this doesn't even take into account any changes that have happened since the pandemic has started. This just shows the trends in where people have been getting their insurance or not over time. And so I think the takeaway from this piece is that we already know that the uninsured rate has been dropping, but there's been a few other big changes. You know, folks have been moving out of uninsured a little bit into Medicare, which is that yellow band, going from 12% of the population to 16%. The biggest change we've seen is in our Medicaid. So back in 2008, only 10% of Oregonians were covered by Medicaid, and that is, well, this says 21%, but it's probably closer to a quarter are covered by Medicaid now. And in large part, that is because, again, of the ACA and the more generous Medicaid eligibility requirements that Oregon has adopted, which has allowed us to cover a lot more folks. As far as people getting their insurance from employers, that has remained pretty steady at around half of the population. And as we know, the level of that insurance, as well as what people are getting in that orange bar, that individual market, the cost sharing and that sort of thing really varies quite a bit. The insurance gains have varied a lot by region. If you are a person who likes data, this actually in the slides, this is a link that to a really nifty visualization of, there's a lot of different maps and visualizations. It's pretty new on the OHA website where you can play around with things, but this just shows by county/region, excuse me, between 2011 and 2019, we see that, you know, lighter colors are better, lighter colors are more insured. And so the whole state has certainly improved quite a bit, but there's definitely been differences in the degree of improvement. So I think it's also useful to understand, especially as we look at issues of health equity, who is still uninsured and why. And I know that there is a difference between what we might see in the data versus what we will get from talking to folks who are experiencing this. But this is one approach to, I think, understanding what's happening with our population. So we see that young adults, 19 to 34-year-olds, are much more likely to be uninsured. In fact, in 2019, almost 20% of them said they had been uninsured at least at some point in the past year, which is pretty significant. We also know that Black and brown Oregonians are uninsured and underinsured at higher rates. And in fact, across the whole population in Oregon, we have a pretty significant percentage of our population that is considered underinsured, meaning they may technically have access to some sort of coverage, but it's really not comprehensive, and it's not probably going to meet the needs that they have. I wanted to draw your attention to one of the handouts that I sent out, which is from the University of Minnesota SHADAC, where it's a nice summary of uninsured rate broken down by a number of different demographic categories. One of the things that really stands out in that, I think, is how being an undocumented immigrant really impacts your ability to get coverage. I think it's like 27 or 28% of undocumented immigrants in 2017 did not have health insurance. So we see that there really are quite a number of disparities. Part of the survey also looked at, for folks who were uninsured, trying to get at what they might have been eligible for and why, or excuse me, what they might have been eligible for and then why they may not actually be covered by those things. So 78% of the uninsured in the Oregon survey were eligible for OHP or some sort of financial assistance. So 52% were eligible for financial assistance through the individual marketplace, which means that they were eligible for some sort of financial subsidies. And we know that that probably gets to some of the affordability piece. Just because you're eligible for subsidies doesn't mean that they are sufficient to allow you to purchase that coverage. And about a quarter of folks were eligible for Medicaid, and including, I think this is pretty significant, 61% of our kids were eligible for Medicaid. And we have a pretty low uninsured rate among kids currently, but still that's a big chunk. A third of Hispanic, 42% of non-white, non-Hispanic Oregonians were eligible for Medicaid. And so I think it gets to, part of a question of something's not working. We all know that, but what is it that's not working there? So people were asked why they are uninsured, and there was a lot of different reasons. A lot of them said they lost their Medicaid coverage, not interested, a lot of cost reasons. It may be that their employer stopped offering coverage, or the premiums were too expensive. And then people were also asked about why they haven't applied to OHP if they're uninsured. And so I have a few slides here that breaks this down by a couple different types of demographic groups. So here we have it broken down by income. So the dark green is low income folks under 138% of the poverty level. The middle green is, I'd say, low to middle income, up to 400% of poverty, and then the lighter green is middle income and above. And certainly not all of these, not everybody is eligible, especially if you have, if you make more money, you're not necessarily going to be eligible for OHP. But there's certainly a lot of other issues here. A lot of other reasons that people, mention as not wanting to apply for OHP. Concerned about high costs without coverage, the quality of care, unfair treatment, whether they'll be able to see the providers that they want to see. When we look at this information by geographic area, so we have our frontier, our rural, and our urban residents. I think one of the things that stands out to me is in our frontier areas, 17% said they wouldn't want government assistance. And as I think about some of the questions before this tag about not just perhaps offering people a path to eligibility, but also helping people take that up and actually get that coverage. Thinking about how this plan might be framed. And then the other one that I wanted to just point out here, actually, I'm sorry, it's in the next one. The next one, which is the same question, but just broken down by race and ethnicity. There's some pretty big differences here as between Hispanic, non-white, non-Hispanic. And again, I wish we had more detailed breakdowns of these, and unfortunately we just don't. And then white non-Hispanic folks, that concerns about quality are very, very at the top of the mind for some folks and not others. Similar about unfair provider treatment and ability to see preferred providers. So I just think this gives some insights as this tag is thinking about not just eligibility, but also access and enrollment. So before I move on to the a few slides on the eligibility options, I wanted to just pause and see if there were any questions on any of the data or information that I just presented.
Yeah, Sarah, I had a question.
Sure.
And this brings us back to a statement you made very early on that I'm trying to understand the wording of the statement. But you said that you showed the graph that from 2011 up until 2019, it goes it goes way back, and then you're talking one more maybe. Yeah, so right here, you were saying we went from 85 to 94% and have stalled. I thought you said stalled because of the Affordable Care Act. Can you talk about, are you able to summarize that? Why would the Affordable Care Act have caused it to stall out, or it got to 94%? So can you unpack that
Yeah,
just a little bit?
sorry. Yes. I didn't mean that the ACA was the cause of the stall. I just meant
Okay,
that we saw a big jump because of the ACA. And
right.
since then, we haven't been able to make a lot of progress.
Okay, that
Yeah.
was my understanding, but the way I heard it, it stood out in the way it was
Yes.
said.
Yes. Thank you. Sorry for being inarticulate there.
No, that was just maybe is the way I was hearing it. My second question is actually going back. Um, I think it was just maybe only one more slide. We were talking about yes here, and so we've seen this slide before, and I've had some people say, why do we need single payer when only 6% of people are uninsured, and of those, and then you went on to say the same thing, 76% of those might be eligible for federal assistance or, Oregon Health Plan or something. And what I believe this does not show is some of the other nuances and layers that you talked about, which is some affordability, some quality of care, but ultimately the people who have jobs, they're unsatisfied with what they're doing, but they can't change what they're doing because they'll lose health insurance. So I think that this is a helpful historical marker for us, and a point of conversation so that we're coming at it from a standard perspective. And there's a lot of narrative buried into these numbers that we don't really say out loud very much.
Yeah, thanks for that, Dr. Junkins. I think you're absolutely right. I mean, it does really mask the issue of this is not the end goal, right? It's just to take more people out of the orange into one of these other categories that
Right.
that there's a lot underlining some of these pieces, especially perhaps in individual market and the group market, that just because people have coverage doesn't mean it's a satisfactory arrangement for them, or they're getting their needs met, or as you said, people stuck in jobs that they are in simply because of the coverage.
And thank you for saying that out loud. And then my last point, and then I'll turn the meeting back over to you, is as you are surveying, is there going to be an attempt to sort of maybe even capture some of those qualitative measures, such as, what this doesn't show, where would you prefer to be insurance-wise if given the choice? And because I think that it is accurate to say that our end goal shouldn't be to eliminate the orange. Our end goal should be to create a system which is fair and equitable for everybody, and achieve a kind of health outcome that we all want. Thank you.
Yeah, I totally agree. I think this survey in particular is kind of a standard tool that's conducted every couple of years, that does not, to my knowledge, have a qualitative component. Although I completely agree with you that it would be really helpful to have that. And I don't know the answer is, as far as what other efforts are underway. I think honestly, this project in and of itself, the more that we're able to engage consumers, I think maybe that is something, maybe that kind of a question is something that we put in front of a CAC or some other stakeholder groups that we might be engaging, because I think that's really important. Thank you for that. Anyone else have, and Michael Collins, I think, just joined us. Welcome, Michael. I'm glad you found us. We made it exceptionally difficult for everybody to get here this morning, but thank you for joining us. Actually, Michael, do you want to just introduce yourself really quickly as a member of this tag?
Yes, good morning, everybody. This is Michael Collins with the Confederated Tribes of Warm Springs. I'm their Director of Managed Care. I live in Central Oregon, and I have a family of 6, and welcome, and let's have a great day.
Thank you. Are there any other questions or comments on any of the data or the slides that I just presented? Okay. So before we dive into discussion, I did just want to put a few slides up here about what is currently happening. What is our landscape of eligibility options for Oregonians as it stands? So one of the things that I had sent out as an attachment was a nice Kaiser Family Foundation summary of Oregon's Medicaid eligibility. But just to summarize that up really quickly, in Oregon, we do have one of the more generous, I guess put that in quotes, but compared to other states, we have one of the more generous income eligibility options for our Medicaid program. Children are up to 305% of the poverty level are eligible. And in the last couple of years, we have adopted or created a program called OHP and Me, which is like a Medicaid look-alike program, and that any child up to 18, including undocumented children, are eligible for that. OHP also covers pregnant women up to 190% of poverty, and other adults up to 138% of poverty, which is, as you can see, not very much. And it also does not cover adults who are undocumented. It's a big driver of our health insurance, though, in the state. So about 1 in 4 Oregonians, between 1 in 4 and 1 in 5, are on OHP, and that includes 50% of our kids, about 435,000. I mentioned earlier that we don't have statewide data on the impacts of COVID on our access to health insurance, but Medicaid has been capturing, their enrollment. And so this was the most recent one from November 9th. And you can see that since the governor declared the state of emergency related to COVID-19 on March 8th, OHP enrollment is up 12.5%, which is pretty significant. And I think we're going to see some pretty big changes in where people are or are not getting their access when we have data from 2020. Other ways that people may be getting their coverage currently, much of this or some of this is federally funded and federally run. We have obviously Medicare for adults 65 and older, TRICARE in the VA, Indian Health Services, and then we have, as we saw, about half of Oregonians receiving their care through their employer. The biggest one of those is PEB and OEB, our public employees and public educator benefits that they cover about 280,000 Oregonians. We have our marketplace exchange, and that's where folks may receive subsidies to purchase coverage that is governed by the ACA as far as the benefits packages that are available to them. That does provide subsidies up to 400% of the poverty level, but that doesn't mean that those subsidies are sufficient for them to purchase the kind of coverage that they want. The enrollment in our exchange is declining in the state, as are the number of carriers over time. We only have one carrier that provides statewide coverage in all areas of the state, and we have 5 total. And then we have a few individual carriers who do not participate in the exchange, but you can purchase private insurance through them. It's just not eligible for the subsidies. So that's a real high level look at the other options to folks. So any questions about those few slides that I just presented, or comments, thoughts? Okay. So now that I've flooded you with some information, and I'm just looking at the time here. So we still have a pretty good chunk of time. We
Sarah,
have,
this is Glenn. I would
yes,
just like to make a statement.
absolutely, thank you.
The statistics that you covered with references to the uninsured populations, the employer-sponsored health coverage populations are just tells us and shows us why we need a single-payer universal healthcare system, and because no one should be left behind. Even the 6% of those uninsured. So what those statistics tells us is that our current system is not working. And so it is so important for us to focus on strategies that are going to include everyone. And with that, I'm going to turn it back over to you. Thank you.
Thank you, Glendora. Yes, I agree. I think we see pretty clearly that there's a patchwork out there. So, and that is not the goal.
Sarah?
Yeah.
Hi, it's Ed again. I wonder if you were going to go back to, I think, slide number 5, questions and considerations for eligibility. Was that, you said you're going to bring us back to that, or is now not the time for that?
Yeah, so this is kind of covered in the discussion questions, but this is what we had presented before, and as we move into our eligibility discussion, I think all of these questions are included in our discussion. So, but
okay.
Yeah, so I think yes, these are all fair game as far as eligibility criteria, dual enrollment, treatment of non-residents.
And I will keep those questions in front of me as we progress. Thanks.
Yeah.
There are some inquiries in the chat section. Should we address those or?
Oh, thank you,
Wait till
Glenda. Yeah, you know,
end?
I can't see the chat when I'm sharing my screen. Let me just take a peek at those. Oh my goodness, it is sunny today.
Yeah, it's a new skill, a new Zoom skill to be able to teach, share, and monitor the chat. You need a co-teacher to be doing that.
I do. Let's see. Yes, I'm seeing folks identify. Oh, and thank you, Glendora. Yes, I'm seeing folks identify some issues, and yeah, some great points. I think that this is maybe something that folks could speak to during their public testimony as well. But I really appreciate all of this chat will be captured. And I think that people have brought up some points about the eligibility options that that I just presented. I did see a question about whether the information presented includes hospital data reports. This does not include hospital data. So this is simply just eligibility, you know, enrollment in certain plans. But please keep questions and comments coming. And if you do want to give testimony at the end, actually, if you would put that into the chat, and Laurel, if you could track that for me, I would really appreciate it. Okay. me go back here. Okay, so we saw in the beginning, I presented kind of what the bare bone requirements are as far as the recommendations, or excuse me, how the plan needs to be defined, and that everybody needs to be eligible. But as well, I've tried to break this discussion up into issues of eligibility and issues of or coverage, eligibility, and then issues of access, which I think are more to enrollment. And I don't think the goal is that we're gonna come up with all the answers today. But as this tag thinks through eligibility, some things that came to my mind were, what concepts are the most important when we're defining eligibility? In some sense, it's a single payer, it's supposed to be a single payer plan and everybody's supposed to be eligible. So that seems maybe pretty straightforward, but what do people think as we're getting into defining eligibility to make sure that we're paying attention to, I think at a statewide level, as well as we can get into sort of people that already have coverage through other options. And then also thinking about how this definition of eligibility or how these concepts that come forward might address existing disparities. So what do people think about what concepts are the most important as we're thinking about recommending a definition of eligibility for the plan?
I really appreciate this, actually, the second bullet point, because that's what I've been thinking is like, everyone is eligible. Right? When I know it's not as simple as that, but that may be a really good starting place for us in this conversation. I mean, certainly I want to hear what other folks are thinking too about eligibility, but that's really what's been on my mind is like, do we need eligibility criteria if everyone is eligible? I know we do need some sort of container to hold that, and I'm interested in what the conversations are going to be here about that.
I agree with Zinnia. Once we start saying everybody is eligible, we adopt a new frame of thinking. Once we move to that third bullet, we are starting to slip back into the old system, because now we're looking at, well, who was eligible under this plan versus this plan versus this plan, when really if we are moving towards something really truly new and unique, we need to adopt a different perspective than what we are seeing in that third bullet. So I would say, I would propose that that we move towards something as simple as everyone's eligible, and then start to maybe put some boundaries around that just to guide discussions of the task force.
Okay, so I believe it is as simple as everyone is eligible, but we have to keep in mind that there are some of those other ones in the third bullet that we don't have control over. So we might want to look at PLR issues, right? How are we going to do that with PLR issues, payer of last resort, right? Who's going to pay first? If they have Medicare and universal task force, or universal health care, who's going to pay on the claim first? If they have some other federal, because the feds always claim payer of last resort. So there's going to be dual enrollments whether we like it or not, because people are going to be in those federal programs.
This is Glendora. Are you done, Michael? I don't want to cut you off.
I'm done, Glenn.
Okay, thanks. I would just say that the Healthcare for All organization's mantra is everybody in, nobody out. That is simple, and it should include, our efforts should include strategies that's going to meet that mantra. So otherwise, we're just spinning our wheels, because even if one person dies for lack of insurance, lack of access, because they live in a rural area, because they are of a ethnic minority, or because they are unemployed, that is one person too many. So we are, as a society, should be focused on preserving life. And to preserve life, we must come together and devise a system that is going to help those out of poverty, rather than to make them feel vulnerable and ostracized because they are not able to afford a healthcare plan that's not going to leave them into bankruptcy. So the statistics only shows the need that we need as a society to change the way healthcare is delivered, organized, and reimbursed and practiced, because preservation and should be the, you know, the first line of defense against preserving life, which is part of maintaining good health status, and will eliminate perhaps many of the inequalities and inequities that the current system imposes upon us, and for no fault of those of us who cannot afford health care. So we got to think big. We got to think not just outside of the box, but beyond the box. And so that's what I would like to encourage our members to contemplate and think about. How do we best do that? And so we need to get rid of this Medicare concept, because what that does is perpetuates classism because of the stigma attached to state-provided healthcare insurance. So we need to think about all these things. I just want to say that, and thank you for the time.
Thanks, everybody. So I love that everybody in, nobody out. I think that that really captures, I think at a high level, maybe captures what I'm hearing from TAG members, and that there may, you know, there are definitely some details under that, some questions. I wanted to just put forward or bring forward a couple of things. I had sent out a link to the Colorado plan, which theirs is a public option plan, so it's a little different. But as I've been looking to see kind of what are other states doing, or what are some ideas about how to define this, I looked to the Colorado plan, and they very clearly in there say that anybody is able to participate in their plan. However, those people who have Medicaid or Medicare or TRICARE or employer-sponsored may be better off staying where they are than participating in the Colorado plan. So I'm just putting that out there as maybe something to react to. When you hear that, how does that jive with what you're thinking this Oregon plan might look like?
This is Xenia. That's interesting. You know, I think I would want to dig a little bit more and better understand, you know, why Colorado made that statement or exception, meaning is it that the federal plans actually offer some sort of better coverage in a way that is less burdensome for the folks who are accessing insurance? Or is it that they're trying to offload a group of folks who would either drive up costs or increase costs for their universal plan? Or is it some, you know, other thing that would be interesting? And I have not read the report, so it's probably in there somewhere. That's really my first thought.
Yeah, I agree with Zinnia. It's hard to interpret that information in a vacuum. It may be apples to oranges, and yet there is a theme in that statement alone that gets back to what Glendora said, which is, that's a class statement in some perspectives. This is good enough for this group, and this is good enough for this other group. And I envision an Oregon plan that would be desirable. So if we get this right, then it would be preferred. And then we don't have to make statements such as that.
Yes, I believe that the Colorado approach has been to maybe lift the bottom, so preserve the structure that is currently available, but to make sure that there is an option for folks. It might just not be the option for everybody. That is different from what I am hearing from you all, but I just want to put that out there because I think that was the direction they decided to go after, some investigation and research. But I think, yeah, it's just a different approach. I do think that somebody mentioned something about not thinking about things like Medicare or OHP, et cetera. Michael, you brought up payer of last resort, which definitely, that's very much our current system, right? Is that we have these different, people are eligible for different programs, for different benefit, different ways of accessing their insurance. With eligibility, I think we're just talking about who can be in, and if the answer is everybody can be in, but underneath that, is it everybody can be in, but all of these other buckets of coverage and options are going to remain as they are? Or everybody can be in, and it may be that employer-sponsored care, which now covers half of Oregonians, the expectation is that does not look like what it looks like now. That more of those folks are not just eligible for, but coming into this Oregon plan.
I would just like to say, are you done, Sarah?
I'm done.
Thanks. This is Glendora, and I would just like to say that what we are trying to do here is not just reform the healthcare delivery system, but to transform it. And to transform it, we have to understand how these components overlap and interact and are interconnected, and how they influence and bear and present with barriers to the very things we're trying to change, such as health disparities, health inequities, and health inequalities. So we want to make this an even playing field for all two-legged animals, right? We call humans. And so to do that, to make everything equal, I'm recommending that we as TAG members keep in mind that this fragmented healthcare system that we currently endure, it's not only a death sentence, it is inhumane. And so for us to continue with labeling the healthcare plans with different names only sets us apart and establishes a judgmental mindset, in that I'm not going to pay for someone who smokes and dies of cancer or gets sick and need preventative care treatment. So we want to transform the healthcare system so that those stigmas and that mindset can be eradicated through an equal health plan that is that will benefit all. And we cannot talk about eligibility without thinking of individual benefits, and we cannot talk about benefits without talking about should everybody be included regardless of their human characteristics or levels of power and position in society. So that's what I want to say, and to keep those things in mind and to present recommendations based on those ideas, I think we will be headed toward a robust change, and this is our only opportunity. So we need to think deep, think long, and apply all of these issues to the work we're trying to do. And it's a huge undertaking, I understand that. And we need all kinds of people at the table, the opponents, the proponents, the impacted, and all ethnicities. Thanks.
Thanks, Glendora. So I guess I want to highlight a little bit of a tension here between a very clear desire for this to be a holistic change and an eligibility, a plan that it's not just everybody is eligible for, but somebody said a desirable plan, I guess. And also to not have so many buckets and gradations and fragmentation of the system. I also want to acknowledge that we have really robust Medicaid program here, and we also have a lot of seniors who are covered by Medicare and folks in the VA and IHS, and that I'm not sure that that folks would be proposing kind of getting rid of those altogether, because a lot of them have federal funds attached to them. And so I guess I just I wanna lift up that tension between radical, well, not radical, but I guess holistic change in a system, and knowing that some of the programs and pathways we have to eligibility now are desired by a lot of folks and are partially funded by other people outside of the state of Oregon. So I think that's just something that I think we should acknowledge as we're thinking about eligibility. So everybody in, nobody out, everyone's eligible. Maybe it is as simple as that for now. And we know from the legislation that this needs to include not just residents, but folks who work here but live elsewhere, as well as their dependents. So they would be included, I think, in the everyone of everybody is eligible. What else do we need to capture, or I guess what else needs to be said about this, about these questions? What else is coming to mind for folks?
I know we just said that we were going to go with everyone is eligible, so I don't want to take us back, but one of the points Michael brought up was around the intersections with federal programs and this like bullet point 3 here and just the greater landscape. I'd love to know, like, where each of those spaces are, like where we need to be considering that. I'm thinking like a map, you know, some sort of a map where we place in, you know, what populations we need to consider in the event that we for some reason cannot do a everyone is eligible, or everyone is eligible also means that we need to be working somehow with or intersecting with, like, you know, federal programs. I think I just don't know enough to know that if we say everyone is eligible, does that mean that there are some folks who, you know, would have to leave like their benefits, and that might influence other benefits that they have? And so where are those intersections at? I don't know. I guess, again, I don't know enough to know, but it just feels like maybe there's some information there.
Yeah, thanks, Dr. Junkier. I think that is really important understanding to have, you know. I think, and one of the principles of the legislation is that people should not it should not be a liability to benefits or coverage that people currently have if they wanted to participate in this plan. And so I think, you know, and I also think this is one of the places where we mentioned yesterday, as we are in the process of bringing on a contractor too, that helping us work through from a regulation standpoint, like the answer to some of that, to some of those questions about, we want to minimize the risk to folks. So I think you're right on. Everyone is eligible, and yet what would people potentially have to give up in order to enroll? I think that is an important question. Michael, I saw you raise your hand. You can, yeah, feel free to jump in.
So the landscape of that, if you look at it as a different types of landscaping, right? You're not looking at a map of Oregon and saying this is where the clusters are, but if you look at, because there's many different factors for, like, for your people on Medicare, that's your elder population, right? And they'd be everyone is eligible, so they'd be eligible over here, and then they'd also have benefits under Medicare. And then we would have to work on how that flows. Same with VA. So you're looking at your veterans that have eligibility through the VA, but they're also, everyone is eligible under the Oregon Universal Health Care Plan. And then you have Indian Health Services, where the Native population has the services that are guaranteed them through their treaties with the federal government for all the land that everybody lives on today. Right? So all of those exist and they're not going away. How do we make that, and everybody's going to be eligible under those plans? The issues, we have issues with that today in the current setup, because of what I mentioned before is, okay, if you're dual eligible and you're enrolled in OHP and you're a Native American IHS recipient as well, OHP at one time says, well, we're not going to pay the claim until they pay the claim. If there's anything left over, we'll pay the balance of it. And same thing with Medicare. Medicare is like, no, we're going to pay last. You guys have to pay before us. And so in our population, that was a big fight, because in the language from Congress states that Native Americans are always the payer of last resort, regardless of any program. So, right, so the VA has to pay first, Medicare has to pay first, OHP has to pay first, and then Medicare pays, you know, after OHP, and Medicare pays after OHP, and Medicare pays after, you know, it's convoluted and it's confusing, and it's law, right?
Yeah.
So if we have everyone as eligible, I think we want to make sure we get to a flow where those people are seen for the care they need. Their health care isn't going to diminish because of who's supposed to pay the bill, right? We want to make sure that bill is paid, and it shouldn't affect the patient. But the way things are set up in today's siloed systems, people's health care gets put in jeopardy, and not only their health care, but their financial situations as well, because of being sent to collections, because these different agencies are fighting on who's going to pay the claim. And in the meantime, the patient suffers because they're the ones responsible on paper and get turned over to collections. So we need to figure out, if we're going to do everyone is eligible, we need to make sure that that flows all the way through to where it doesn't affect the patient and they're getting the services they need without any harm.
This is Glenn. I would just like to say, yes, Michael, I agree with you when we start trying to figure out who's going to pay what. But what I would suggest us think about is what should be the first puzzle that we consider in addressing the issues of the outcomes of the current healthcare system. We want to get away from this this multi-payer system. We want to include an insurance plan that's going to reject no one, right? So I'm not saying that this is an easy feat, but it does require us contemplating on patient first, cost secondary, not cost first, and then patient die, because get sick, die quick would be the consequences of us focusing on cost first. So I would like to encourage us to think about lives saved, and how can we do that without it conflicting with our thought processes in how are we going to pay for it. Okay, I think there is a way. I'm very optimistic. We can do this, but we got to think long, hard, and deep. We have to understand the impact that this current system has on individual lives. And when I say individuals, that include family members. So I would like us to dig way down deep and find that ounce of water that is going to preserve the thirst for all humanity. And so that's where I'm at on this, and that's where I'd like to see us go. We can do this, and there is a way without parsing up these categories of insurance health plans where people walk away feeling less than, and others walk away feeling more than. And those are the kinds of stigmas that we are trying to eradicate in this transformation of healthcare. And it cannot be on who's going to pay what. So everybody pays, everybody receives, and less people die. Nothing is going to be 100% because this is a social construct. Social construct has an outcome of uncertainty. So it doesn't mean that we can later address an issue that we did not anticipate. But right now, I think we should anticipate any negative, any opposition, and we're not going to be able to identify all of the negativities, but we can, address many of them.
Sir, can I make a comment?
Yes.
Thank you, Glendora, for that, reminding us about the social constructs. I'm going to bring us back to the mandate, Senate Bill 770 and Section 6. So I just wanted to read into the record real briefly what Section 6 calls for. And Section 6 says, scope of the design of the health care for all Oregon plan by the Task Force on Universal Health goes on to say, C, ensures that individuals who receive services from the United States Department of VA Veteran Health Administration, or the IHS may be enrolled in the plan while continuing to receive the services. And then later on, under subsection E, preserve the coverage of the health services currently required by Medicare, Medicaid, Children's Health Insurance Program, and Patient Protection and Affordable Care Act, as amended by the Healthcare and Education Reconciliation Act of 2010, and an Oregon's Medical Assistance Program, and any other state or federal programs. I think the spirit of that language means that that third bullet, while everyone is eligible, we need to continue to have conversations about these as provided in the bill. Okay.
Sarah, could I make a comment?
Who is that?
It's me, John Santa.
Oh, hi, Dr. Santa. Sure.
Yeah, I'm not part of this tag, but just a couple comments. First of all, I learned when I worked for an insurance company for Blue Cross Blue Shield, the costs of eligibility systems are enormous. When half of the administrative costs at Blue Cross Blue Shield when I worked there were in the membership systems, not the claim system. And avoiding an expensive eligibility process could enable really significant cost savings. The second thing I wanted to make sure you know that many folks in Oregon don't appreciate is the Oregon Medicaid program uses retroactive eligibility for Medicaid. So, I mean, right now there's 80,000 people who are eligible for Medicaid in Oregon, but they're not signed up on the plan. If one of those people goes to a hospital and is admitted, the hospital signs them up, and the hospital is paid. Okay, it's really great. So, you know, to some degree, I think you could have a very simple eligibility process and retroactive eligibility so that the sequence that Glendora referred to and Michael will not happen, that nobody in Oregon, nobody's healthcare in Oregon should be delayed because of some eligibility sort of thing. The third point I'd make, though, is I think one of the trickiest things you all have is if you are going to consider employees of an Oregon company who live in another state to be eligible, that's going to be tricky. That's going to be really tricky to administer and figure out. And potentially expensive because, you know, the plan would not have any relationship likely with much of a delivery system out of state. I think that's one of the trickiest things of taking on, you know, employer-based coverage, what to do with the people who work for an Oregon-based company like Nike, but they have employees all over the world. So don't forget that. I mean, my own bias is I think you could do something incredible for people in Oregon that got rid of all of this eligibility stuff that we just waste so much money on. Figuring that out for people outside. You know, the other thing I would say, having worked in the VA is going to keep taking care of Oregon veterans. They're probably not going to pay anybody else to do so. That's not impossible, but that would be quite the accomplishment. So veterans have double coverage. Not a big deal. And you know, certainly no veteran anywhere in Oregon should be not treated because, oh, you got VA benefits, go to the VA. You know, no. So anyway, sorry. I just tuned in to kind of listen and just my 2 cents.
Thank you, Dr. Santa. I think you brought up some really helpful points for us to think about. I guess a couple thoughts that I have, you know, as far as the eligibility system, sort of those administrative costs, you know, having something that is streamlined, which I know is in some ways kind of a administrative detail, if you will, and yet costs an awful lot of money. So I think that that is an important thing to note, you know, to the ability to have an eligibility system that is somewhat streamlined. The point you brought up about Oregon companies who have a lot of out-of-state folks, I think this is a tricky one because the bill is pretty clear about that everyone would have access or be eligible for the plan if they work full-time in Oregon and contribute to the plan, however that is defined. So, I mean, we do have a model with, you know, we certainly have state employees and who live in neighboring states who are covered under Oregon's PEB plan, but not folks who are living, you know, halfway across the world. So I think maybe that's something to maybe put a pin in.
Yeah, you know, I think that, Sarah, that came up in the discussion of Vermont. I think it was an issue in Vermont because, and I believe that, you know, they decided they needed to cover employees of Vermont-based companies who lived and worked in other states, and that was a significant issue, and that's just something to think about.
Yeah, and I'm not clear if a company based in the state counts the same as being a non-resident but working in Oregon. Like there may be some nuance there. One thing I wanted to just propose to see if it would be helpful for people as we think about, okay, there are these big buckets of coverage like the VA. The VA is going to continue to exist. Medicare is going to continue to exist. IHS is going to continue to exist. I think back to Dr. Junkier's original point about just not having a good understanding necessarily of what it might mean for somebody enrolled in Medicare to have another coverage available to them. I'm wondering if having, you know, some materials, you know, whether it's like almost like a map, not a map, but I don't know, flow chart or something that kind of lays out, or a grid that kind of lays out like, what are some of the issues that we would need to consider specifically for OHP enrollees, specifically for people who get care through the VA, so that this system would truly be patient first. But I think understanding, you know, whether it's who's paying first or, you know, issues of benefits or, you know, rules about having multiple coverages to help us maybe avoid some of those landmines so that we're not unintentionally putting forward a system that would, you know, trap people or where they would suffer unintended consequences. So I'm just kind of thinking out loud here about having something that is an overview for each of these other eligibility options that might give us some guideposts as we're thinking about everyone is eligible, and also how do we make sure that that eligibility doesn't have unintended consequences for folks if they're in other plans.
This is Glenn. I just want to say that this is not a, whatever we decide, we need to make certain, to the best we can, that we do not omit any parts of the services that are intended to equalize, improve quality, and lower costs. That is our Oregonian aim. And because we expand care and have expanded it through the federal ACA, it still leaves people out. So we're going to have to consider what services, what policies, what practices are going to ensure preventative care access, are going to improve quality of care, which is more than just a measurement of how the services are delivered. It is the impact that it has on the people that seek care and are, whether advertently or inadvertently, are burdened with poor health outcomes because of lack of quality care based on either the facility or the provider. So these are deep, long and festering issues that we're going to have to think about. And then we get to what is it going to cost and who will pay. So I would encourage us to think along those lines. And then we can get to the, address the eligibility issues. And as I said before, keep in mind that these are iterative processes, right? These components, they all work to influence the other. And if we don't get the strategies correct and anticipate a positive and outcomes, it is going to be difficult. So just like to encourage us to keep that in mind.
Thank you, Glendora. Yeah, I think, you are definitely highlighting the fact that the conversations we're having here cannot happen in isolation. And I actually, sorry guys, I have a couple other slides and I apparently pulled up the wrong presentation. I guess I just want to maybe highlight that or bring to folks as we think about what other tags are really being influenced by these discussions, because I've heard a lot of that. And so we know that a lot of these conversations are really influential on obviously the finance and revenue tag, because we're having a lot of talks about cost and making sure that cost is not the driver. I think the responsibility of this tag is to put forward some recommendations and suggestions that are cognizant of that, but also knowing that that cost is not the deciding factor in what we're putting forward. So I support what you're saying, Glendora. I am looking at our time, and I know that we have a number of questions, a couple questions that we definitely need to get to before we get to public testimony, and I believe we do have some public testimony. I also want to think about what is most helpful to folks in moving through some of these recommendations, because we've identified a lot of things that feel unknown, I think. I mean, what I've heard clearly is everybody's in. We want this to be something where everyone is not just eligible for, but it is something that is desirable. It is not just another segmentation of our health insurance system, but it is a true universal plan. And also that we need to understand what that would mean for folks who have other coverages. That's not the whole discussion, but to me, that's one thing that I heard that we need to dig into a little bit more. I'm wondering what people feel like they need to get at, to keep this conversation of eligibility going. What would be helpful for you, whether that's information or other things?
This is Xenia. Sarah, you had mentioned earlier some kind of map. I'm a not only visual learner, but I recognize that I have a lot of gaps here that I'm trying to fill. And so some kind of map of understanding if, like, you know, Medicaid and, you know, IHS and VA, like what are those all the bodies that we need to be considering, or you know, the streams through which funding is allocated, or the, you know, payers, or whatever that
Yeah.
definition for. Yeah, I would love to be able to see that, if that's something that you all could put together. Or
Yes.
okay.
Yeah, I think something like that would be really helpful as well. And I think as we move into our next tag meeting, well, I'll say what I want to say, and then I want to hear from other folks too. But as we move into our next tag meeting, which at this point we talked about, you know, moving into benefits, whether we're ready to do that or not, I don't know. But it could be something that kind of helps us throughout this whole, all of our tag meetings. So it's not just necessarily about eligibility, but also about benefits and funding and payment and that sort of thing, as a visual reference, I guess, is what I'm thinking. How does that sound to other people?
I think that's a good way to start it, because it isn't so much as who pays as to where the service is available under IHS and VA. So IHS is an actual facility, and the VA is an actual facility, right? And so yeah, I understand what you mean, because I'm kind of the same way too. I want to see a map or bubbles or something where the dots connect and it looks like molecules, and I can kind of read that a little better. But yeah, I think if we do, it'll all fall into place as long as we go back to enrollment for all, and underneath that, somewhere in the mix is, you know, I think enrollment for all, and we can figure out a mechanism on those other patients, because you're still going to, people at the VA are going to go to the VA. I don't know if the VA currently charges OHP or if it comes out of VA funds completely. You know, at IHS, if somebody's on OHP or private insurance, IHS is going to bill OHP or the private insurance. So everything's set up differently, and that's what's so convoluted about the country's healthcare systems, is everything siloed, and having universal healthcare is a way to bring that all into one bundle and make sure that nobody gets left out. So yeah, I understand you wanting to see a map. That'll be one heck of a difficult map to draw.
Sarah, I agree with both Michael and Xenia. A map would be helpful. It sounds like quite a task, although it seems like you are able or willing, certainly, to put something like that together. I wanted to add to maybe a high-level summary of the discussion today, a couple of John's points, which speak a little bit to the sub-bullets here about people who aren't enrolled and mandatory versus optional. But the high-level takeaways that I'm starting to coalesce around are that everybody's in, nobody's out, and that maybe we should have more conversations about, retroactively enrolling people in the moment so that everybody gets care, as one high level concept. That that enrollment is simple as we then work towards efficiencies that would inform the financing tag, the efficiencies that could be really quite huge, and the cost savings because of the lack of significant administrative costs for eligibility alone. And then the last high level take home that I see is that we should be working towards a comfort level in double coverage and expanding the conversation about, what if these other things are in play, which brings us back to the map, which sounds complex. So those are kind of the high level items that I'd like to see carried forward out of this conversation.
Thanks so much. Oh, go ahead.
Yeah, this is Glenn. I think perhaps it may be a good idea to introduce some of these topics and details we've discussed here today with our Consumer Advisory Committee and allow them to provide feedback to such that, we can decipher what route and prioritize our strategies in providing for eligibility and enrollment process, and present to you guys the questions to ponder and consider and bring them back at our next meeting. Does that sound like a plan?
That's like the perfect segue, Glendora. Thank you so much, because I think, we definitely want to make sure that we are identifying some pieces to go in front of the Consumer Advisory Council. And it sounds like there are a number of things today that have come up, but yeah, what is on people's mind? I mean, what do you most want to flag, whether it's specific questions or concepts to put in front of consumers?
Or would you like for me to initiate that conversation according to evidence-based practices and what we're facing with having to decide over? I'll be happy to, just so that the responsibility is not given to Sarah. So she would have to do our work for us because she is to help facilitate the information that we need to arrive at decisions, and not necessarily tell us what we should be considering.
When? As you go back to the advisory group, the community advisory group, and again, I think it's a golden opportunity that we have you in both, with your hands in both pots, if you will. But would you guide a conversation that circles around what would you be willing to give up, or would you be willing to give up? The 10 to 12 people who are in the room with you have been selected to represent each of these groups, and there will be people who can talk very, very clearly about their experiences with these plans. And I would ask, would you be willing to give these up for another plan, and what would that look like, and what would it take, and where's the tipping point, or gaps in coverage, or their experience in coverage? So I would ask the question very clearly, what would you really be willing to give up for a universal plan? Because I think that would inform this group considerably.
Okay, I hope we got that captured so we don't overlook that important question.
I got it, Glendora.
Thanks.
Yeah, and I that's such a great question, Dr. Jenkins, and you know, I think that kind of thing would be really fruitful to get in front of consumers and get their experiences. I also wonder about even just presenting some of the high level pieces that we've talked about today. Here's where we're at. Here's some of the things that this tag feels pretty strongly about as far as a general statement of eligibility. And here's the places where we're struggling a little bit, or not struggling, but just need more information around some of these dual eligibility pieces. Okay. Other things we want to make sure we talk about or just raise here, you know, for all of our ears, but Glendora especially, as we think about engaging the CAC on this topic.
Well, I would like to extend an invitation to the members of the EBA tag. If you should happen to have a question that you would like CAC to address, Sarah, can we establish where would they, who would they contact to propose that question? Perhaps me, and then I, you know, send it on to you. How will that? How do you think that process should work? Because Zinnia had mentioned that she would like some preparation time before our meeting to provide some you know, thoughtful input that's meaningful. So, and I agree with that approach. So I think that would be, that would help us, you know, with our work going forward. So yeah, go ahead.
I feel like I heard two questions in there, so I just want to make sure. The first thing I heard you ask was about if folks had a question they wanted to ask to the CAC, what's the best way to communicate that? I think the answer, I would like to just I'm trying to track all of the activities of the tag and the discussion. So it would be wonderful if that came up, for someone to be able to email both you and I. But I think if they just emailed one of us, then that's fine, and we can just share with the other person. Does that feel okay to you, Glendora?
Yeah, I like that. Email both of us, because if it escapes me, then you got it, and vice versa.
And then the second thing I heard you say was about having time to process information to be prepared for discussion. Yes?
Yes.
Okay.
Given
Yeah.
the time that they present us with their inquiries, then we can develop some sort of 7 to 10 day time duration to you know, well, what I would like to see, what I'm thinking is, and the members can tell me, how much time would you like to have to contemplate on a question to expand upon by our next meeting? Would you like 5 days, 3 days, 7 days? Because we're all double, triple dipping here.
Yes. Yeah. So I think that is, maybe that's a conversation we can have and figure out. And yeah, posing that to them about the time allotted, or the time that they would want to be able to have some of that information up front. So I'm just checking in with Laurel here, and it looks like we do not have any oral testimony. Oh, okay, thanks, Dr. Jenkins. We do not have any oral testimony for today. I just want to flag again that people can submit written testimony through the website, which I will show here in a minute. I did want to just revisit that what we had talked about before was that this meeting would be about eligibility and enrollment. The next meeting would be about covered benefits, and then our third or fourth meeting, I guess, would be about affordability. I know the provider tag has scheduled 1 or 2 additional meetings into 2021, and I wanted to pose that to folks here, whether that is something that you would be interested and willing to do. Do you feel like you want more time on the calendar to process some of these things? I guess that's the first question.
I think that if we can nail down now what the members, the time span from us developing the question to getting it to them before, then that would help. Then that would help to address the future meeting questions here. So would you like 5 days previous notice to entertain a question, to provide your feedback and the why position that you've taken on that particular question? Why do you think it's important, and any other feedback you have to address that issue? Because eligibility, I mean, we just don't want to get in the habit of making a statement without defending it. So I want you to have time to contemplate it, because Xenia, you stated before our previous meeting that you'd like more preparation time. And I agree, because these are things that should not be decided on the fly. It should be we should have time as members to, you know, think about the ramifications of our answers, and you know, the other unexpressed issues that impact eligibility and benefits and affordability. So how much time would you like to have for preparation time before our next meeting?
This is Xenia. I mean, I think, you know, 5 to 7 days is always great if the preparation includes materials to read, et cetera. I think where I'm getting a little maybe confused with the conversation is I'm trying to figure out when we would finalize the conversation that we're having today about eligibility, and then when we would begin the conversation about covered benefits. It seems like we either need another meeting or a space. I, like everyone else, am like maxed out of meetings, but so I'm not putting it out there because I just want to meet. But I do think we need to wrap up this conversation. And so if there's going to be some sort of a map put out there, or that Sarah's going to put together, excuse me, or, you know, opportunity to read some of the materials out there before the next meeting so we can answer some of the questions that came up at this meeting. You know, that depending on, you know, how much work there is to do, I you know, for me, a handful of days. I could also turn it around in just a small handful of days. You know, I have had no problem with the way that materials have come out so far, so I'm good with the schedule. Thank you.
Yeah, Glendora. So I think that, you know, a few days is fine, 3 to 5 days is fine, advance notice of getting the materials to review them. And then for like today's meeting where we have discussion and there's items that we need more information on that were requested, if we could get those get the material that is found for those items along with the new items for our next meeting, maybe we can take the first, I don't know how much amount of time at the beginning of the next meeting to do a small recap of our previous meeting to tie those loose ends so that we can say, okay, we got eligibility and enrollment. We had these questions. We were waiting for feedback coming back. Now we got that, reviewed it. Let's take care of old business at the beginning of the meeting to tie those up, and then we can get into the covered and benefits. Then when we get to the next meeting on affordability and cost, if there's anything lingering over from covered benefits, and we can take care of those at the beginning of that meeting. Does that sound reasonable?
You're making the decision. I'm just leading you through it. If you like it, I love it.
Okay, that's what I would suggest.
I think one of the things I forgot to flag in the beginning, but we do have kind of a, I think, Michael, to your point, a template for summarizing the past meetings, which sort of kind of gets to like, what were the high level questions, what things still need follow-up, what's unresolved, etc. And for the first meeting, that was more generic. I think for this meeting, we'll be a little more pointed as far as what are some things that we really did kind of land and other things that are still outstanding. You know, I once again want to apologize for sending out slides last night at 6 o'clock or whatever time that was for a 10 a.m. meeting. That will not happen again. I will, you know, we'll try to get materials out, you know, 3 to 5 days before the next meeting. Dr. Junkier, to your point about, yeah, I mean, clearly I think we're not ready to kind of quote unquote move on. We do want to be thoughtful. And so our next meeting, I think on the 3rd would be continuing this conversation. You know, I think Glendora and I can talk. I mean, one thing I think it would maybe be helpful to be really clear about what are the questions we really need to answer, and maybe what are the questions we need to send elsewhere, like they go to other tags, or they go to the CAC, or they go to the task force. So just letting us kind of work through some of these things pretty clearly. Maybe that means we kind of punt on this decision right now about additional meetings. I am certainly open to whatever you all want to do. I've just been reminded that we are actually only allowed to schedule one more meeting before going back to the task force and kind of getting task force permission to have additional tag meetings. 5 is kind of the max. But you know, I think we could postpone that decision until we meet on the 3rd and see where we're at, if that's the direction that people would want to go. How does that sound to folks?
So will you repeat that, Sarah?
I'm asking if we want to postpone a decision about additional meetings. So on the 3rd, December 3rd, our next meeting would still be focused on eligibility and enrollment. We would try to, I think, land some more of our recommendations that are going to come out of the tag before moving on to covered benefits. And at that point, we could make a decision about whether this tag needs another meeting beyond what has already been scheduled.
Yeah, I don't want to rush through anything. We're rushing through these scheduled meetings too fast. So we want to give we want to give the due diligence and to make informed and meaningful decisions. We only have one opportunity. This is it, folks. And we need to give the due diligence that this topic is due, so that at least we can anticipate what we didn't cover, why we didn't cover it, that kind of thing. I don't want us to go forward without establishing some anticipated objective outcome. Does that make sense? So if it does, then Sarah, I would be in support of what you just said.
Yes, that makes perfect sense. Okay, so I think we'll move forward with that plan. look for some materials coming out from Glendora and I in preparation for the next meeting, more than 15 hours before the next meeting. And we'll be focused on continuing our discussion on eligibility and enrollment before we move to benefits, so that yes, we clearly have more things that need to be discussed. So that is where we will land today. And I think we are right at 12 o'clock. So I want to thank you all for finding us and bearing with our technical difficulties. I think this was a really rich discussion, and I think we're making some really good progress. So thanks to everybody for your time. If you have anything you want to touch base on afterwards, I mean, obviously, please feel free to reach out to Glendora or myself, and we'd be happy to chat. So
Thanks, everybody.
thanks.
Great, thank
have a great
you.
day.
We'll see you later. Thank you.
Bye.
Bye, everyone.
Bye.
Oh boy.
I'm scared to talk because I think it's going to create feedback.
Oh wait, let me stop the